Pancreatic tail mass 1.8 into 1.1 cc. Hypervascular scintigraphy showed non-functional tumor, one of the most common tumor of the pancreas. What is the management? What could be the answer? So, non-functional tumors, the management, and it is hypervascular. Yes. So, the treatment remains spleen preserving distal pancreatectomy. For tumors of the body and tail of pancreas, the standard surgical approach is distal pancreatectomy with splenectomy. This procedure is typically performed for resectable tumors, including those with tumors involvement of splenic artery, splenic vein. Infiltration of the splenic artery or vein with the tumor is not a contraindication for the resection as long as the tumor is fully excised, which is often necessary for an adequate oncological control and staging. See, here the Bailey and Lau, 28th edition, page number 1284. What you need to understand is, here it is a non-functional pancreatic tumor where the spleen is not involved. So, we will do a spleen preserving distal pancreatectomy because treatment of choice for non-functional pancreatic tumor is always surgical excision, because before it becomes metastatic and before it becomes get into complication, it is always better to remove the tumor. So, and it is because of hypervascularity and it is always better to do it electively. So, the answer will be option B. Okay. Thymoma classification, what is the name? So, the answer is very straightforward and most of the students will definitely know this, and it's a very straightforward classification. It's called Masoka classification. The Masoka classification, it very clearly says stage 1 is completely encapsulated for thymoma. 2A is a microscopic invasion to the capsule into the surrounding fatty tissue. 2B is microscopic invasion to the capsule. 3, macroscopic invasion to the adjacent organs. 4A, stage 4A, pleural and pericardial implants, and 4B, lymphogenous and hematogenous metastasis to distant sites, extrathoracic. So, this is about Masoka classification. Thymoma is the most common mediastinal tumor. Understand this, accounting for 25% of total, and is derived from thymus gland. And this is according to Bailey 28th edition. But actually, if you ask me, what is the most common mediastinal tumor? It is a neurogenic tumor. The most common location is posterior mediastinum. Thymomas vary in behavior from benign to aggressively invasive as reflected by Masoka classification system used for stage thymomas. Most recently, TNM classification is also available. They are often related to myasthenia gravis, neuromuscular condition that can have a high associated incidence of thymomas. Interestingly, may respond to excision of thymus gland even when the gland has no associated thymoma present. The only reliable indicator of malignancy is capsular invasion. Understand this. Myasthenia gravis. There are certain conditions for myasthenia gravis, and removal of thymic tumor and thymus has a significant improvement rates. Now, the treatment of choice for a thymic tumor, thymoma, is, you know what it is? Radical thymectomy. You know what is the meaning of radical thymectomy? Radical thymectomy. Can anyone tell me this? See, radical thymectomy, no fat should be seen in this boundary. What are the boundaries? Right to left, phrenic nerve of the right side, phrenic nerve of the left side. So, from one phrenic nerve to the other phrenic nerve, yes, then clavicle to diaphragm. No yellow tissue. Understood? No yellow tissue, because it's very difficult to differentiate between fat and thymic tissues. So, all yellow has to be excised from phrenic to phrenic, yes, clavicle to diaphragm. Radical thymectomy. Have you all understood? So, you will say, sir, clavicle above or suprasternal space, jugular space to clavicle above and diaphragm below, and right to left is my phrenic nerve to phrenic nerve. Clear? So, whatever the fat in this boundary, I will remove it in toto. I will not leave even a single yellow tissue. Clear? Yes, there we go, thymoma. They will ask you involvement of heart. Next question. The involvement of heart in Masoka classification is what stage? You tell me. This question has appeared earlier, can appear in future also. Involvement of heart is stage? Correct, stage 3. This is a standard entrance question on thymoma. Okay. Any organ, but heart is the most common organ because it is the nearest and adjacent organ. Excellent. Correct of electrocautery. Of the statement, what is correct? These are standard areas for entrance. One question on cautery, one question on mediastinum, one question on pancreas. Yes? What do you think as an answer is? Cutting low voltage, continuous and high amplitude, monopolar used in tracheoesophageal groove, bipolar pad, sideburn is common, monopolar don't need pad. What do you think as an answer is? The answer is option B. Monopolar is used for delicate tissue. Why? What is read about option A? Cutting mode is monopolar artery is a continuous waveform, not low voltage. It involves high frequency, low amperage and small electrode contact area to focus thermal energy and minimize coagulation. It does not focus on high amplitude. The goal is to minimize thermal spread while cutting tissue. Is it okay? What about monopolar? Monopolar cautery is often used in delicate areas like tracheoesophageal groove, where the precise focused cut, subsistent 21st edition, is needed. Monopolar device requires a grounding pad and delivers current through a small contact area of the electrode and producing a focused thermal energy. Bipolar pad, it is between the two prongs. Bipolar is between two prongs. Pad sideburn is common. The bipolar electrosurgery, the electrodes are in close proximity and the current passes between them, only them. So, there is a minimal thermal spread beyond the tissue between the electrodes. So, the grounding pad is not required. So, the sideburns are not common in bipolar cautery. Okay. Monopolar do not need a pad. They need a pad. Monopolar requires a grounding pad. That is already known. The pad is of essential for completing the circuit by returning the current. Without the pad, the current cannot flow properly, potentially causing patients injuries and burns. Okay. TPN central line. What is the reason? Correct. Obviously, it is because, yes, it is because hyperosmolar. Exactly. Low osmolarity will give in peripheral lines. 11th edition of Schwartz, page number 79, which clearly says TPN, also referred to as a central parenteral nutrition, requires a large diameter of the vein to deliver the entire nutritional requirements of the individual. Dextrose content of solution is in high 15-25% of osmolarity, and all other macronutrients are deliverable by this route. Lower osmolarity of the solution is used for a peripheral parenteral nutrition, PPN. Secondly, to reduce the levels of dextrose 5 to 10% and protein 3%, allows it to administration via the peripheral veins. Some nutrients cannot be supplemented because they cannot be concentrated into the small volumes. Therefore, PPN is not appropriate for repleting patients with severe malnutrition. It can be considered if the central routes are not available or if supplementary nutrition support is required. Typically, PPN is used for short periods, less than 2 weeks. Beyond this time, TPN should be instituted. Very clear? It should be very clear. So, central line for TPN is the reason because hyperosmolar content is given. Correct? Okay, refeeding syndrome prevention. This is a repeat of a repeat. Refeeding syndrome prevention by. When I discussed a high yield and expected questions, and students said 5 to 6 questions, same were asked in the exam of the repeat areas. Yes, the right answer for this question is, the options were slow TPN, gradual increase in calories, thiamine supplementation, frequent monitoring. The right answer for this is gradual increase in calories. The main underlying pathological process is one of hypophosphatemia, resulting in fluid and electrolyte shifts between the intra and extracellular compartments. Patient may develop arrhythmias, muscle weakness, respiratory or cardiac failure, edema, lethargy and seizures. At its most severe, syndrome can be fatal. Laboratory tests will reveal low levels of phosphate, potassium, calcium and magnesium and lactic acidosis. Nutrition support in this group of patients should be started at a maximum of 10 kilocalories per kg per day, aiming to increase levels slowly to meet the full needs by 4 to 7 days. Okay? Very, very clear. So, you need to increase, see, aiming to increase the level slowly to meet up the full needs in 4 to 7 days. This is the most important. Okay? Most important. Clean contaminated surgeries. Among the surgeries given here, which looks like clean contaminated. What do you think is the right answer is? So today will be a short and a good class. Because the questions are asked in exam, we are discussing with reference. All of you are right, 100 marks to all of you. The right answer is appendicectomy. Okay. So this question is a standard question for any entrance. 21st edition of subsystem, even Bailey is also given that, 208 in subsystem, clean wound. An uninfected operative wound in which no inflammation is encoded or the respiratory, elementary or genital or uninfected urinary tracts are not entered. Now, clean contaminated is an operative wounds in which the respiratory, elementary, genital tracts are entered under controlled condition. This is very important. Under controlled condition. Clean, not entered. This is entered under controlled conditions and without unusual contamination. Especially operation including biliary tract like cholecystectomy, appendicectomy, involving vagina, oropharynx, provided no evidence of infection or major break in the techniques is encountered. Contaminated, open, fresh accidental wounds. In addition, operation with major breaks in the sterile technique or a gross spillage from the gastrointestinal tract or incision with an acute or non-purulent inflammation is encountered, including necrotic tissue without evidence of purulent drainage. Okay, next is dirty wound. These are old traumatic wounds. This was asked once. Old traumatic wounds comes under what? With a retained devitalized tissue or those with involving existing clinical infection and perforated viscera. Organism causing post-operative infection were present in the operative field before the operation. So this is as given in the textbook. Okay, as given in the textbook. So the appendicectomy will classically come under clean contaminated. WHO checklist does not have what? Time in, time out, sign in, sign out. What will not be there? What is the most appropriate answer here? All of you, answer please. Answer is time in. So, Subsystem 21st edition, page number 208. WHO surgical safety checklist includes sign in before the induction of anesthesia. These steps include confirming patient's identity, surgical site and other important details. Time out. These steps occurs just before the incision is made. It is final check to ensure all the team members are aligned regarding the patient's identity, surgical site procedures and any concerns. This is time out. Sign out. This occurs after the surgery before the patient leaves the operating room and involves confirming that all the necessary items were completed and accounted for, like specimens and any concerns. However, WHO checklist does not specify, see, time in. Understood? So, time in is not a formal part of WHO checklist. The critical checks are sign in. See how beautifully it is then, sign in, time out and sign out. See, if such statements are given in the book, why the examiner will not pick up a question? You tell me. Why the examiner will not pick up a question? The same question comes next time. Will you be able to answer? Yes, of course. So, if not you have read, what would be your answer? Just tell me. By just looking at it, you are with a common sense, what you would have made as an answer? Because nobody attempted this question. Now, I want, what would have been your answer? Definitely would have not chosen time in, because you want to know time in and time out. This is one of the most important, probably you might have thought. What would have been your answer? Just type, na? I want you to type. I want to just see. CRD. Yes. We will think how time in cannot be in checklist. Yes. Anyway, so you have known the right answer. That is the most important thing. Hypercalcemia, raised PTH, what should be the investigation? So, increased calcium level, increased parathermone. So, could be a hyperparathyroidism. And the most common cause of hyperparathyroidism, primary hyperparathyroidism, parathyroid adenoma. The right answer is system AB scan. Okay. In case of hypercalcemia and raised PTH, so Bailey and Love, 20th edition. Okay. The most appropriate investigation would be system AB scan. This scan is specifically used to locate the parathyroid adenomas, which often causes primary hyperparathyroidism. See, word to word. The most common cause of elevated PTH and calcium levels. System AB scan helps to identify the overactive parathyroid tissue. FDG PET is generally used for cancer imaging and is not suitable for investigation of hyperparathyroidism. Bone scan is typically used to evaluate bone disease such as metastasis or osteomyelitis, but isn't specific for a cause of hypercalcemia and raised. Is it clear? Hello, excuse me, is it clear? The right adrenal mass with 13 into 14 centimeter with renal vein extension, what is the management of choice? So, renal vein extension, right adrenal mass, adrenal cancer, pheochromocytoma could be, or adrenal carcinoma could be. Yes? Yes or no? What do you think your answer is? You need to type whatever comes to your mind? En bloc with nephrectomy. En bloc. The most important factor influencing adenocortical carcinoma is adequate resection. The patient who undergo complete resection is 5 years survival rate is 30 to 48%, whereas the median survival is less than 1 year for those undergoing incomplete excision. For adenocortical cancers, en bloc resection is a standard treatment, which involves removing of the tumor along with any contiguous structures such as diaphragm, kidney, pancreas, liver or inferior vena cava if they are involved. The type of resection involves clear margin and minimize the risk of recurrence. Very, very clear. So here, involvement of renal vein, so you to nephrectomy is added. So en bloc resection with nephrectomy. 60-year-old with halitosis, retrosternal pain, swallowing difficulty, manometry, IRP30, 40% swallow, paraesophageal pressurization, panesophageal pressurization, diagnosis, correct, type 2 achalasia. Excellent. So symptoms, halitosis, retrosternal pain, swallowing difficulty. Manometry finding, IRP 30 mm. This indicates impaired LES, relaxation, and IRP more than 15 mm is abnormal, diagnostic of achalasia, 40% panesophageal pressurization. So this is most distinguished feature of panesophageal pressurization occurs when the esophagus uniformly contracts with a single compartment because of peristalsis is absent. This is a characteristic feature of type 2 achalasia. Classical, na? So Bailey and Love, 28th edition. 80-year-old with a known case of cholelithiasis is an intestinal obstruction. Cholelithiasis, intestinal obstruction, diagnosis. What do you think the answer is? This is Rigler's triad. What is Rigler's triad? Can you tell me? Rigler's triad. Pneumoblia. Then what? Intestinal obstruction, gallstones. The most common site of obstruction is? Most common site of lodgement. The most common site of lodgement of the stone is ileocecal valve. Ileocecal junction, the ileocecal valve. Okay. That causes small intestinal obstruction. The most common causes cholecystoduodenal fistula. Cholecystoduodenal fistula. What else can happen? Cholecystoduodenal or cholecystojejunal. But the most common is cholecystoduodenal fistula. Okay. Bedsore debridement, again sloughs and pus. What is the next best management? Yeah, repeat. If a bedsore is again this thing with sloughs and pus, you have to again do it. Repeat debridement. So managing a bedsore that has undergone debridement but still patient presents with slough and pus, the next step should be focus on further debridement to remove the necrotic tissue and reduce the bacterial load. This approach is essential to promote healing and prevent infection progress. Negative pressure wound therapy is considered after achieving a clean wound base, and it promotes granulation tissue formation, reduces the edema. However, initiating negative pressure wound therapy in the presence of slough and pus is not recommended, okay, due to risk of sealing in infection. Hyperbaric oxygen therapy, meshed skin grafts are typically reserved for advanced and non-healing wounds after advanced debridement and infection control. Their use without first addressing the necrotic tissue infection may not be. POD3, APR, tachypnea, chest pain. What is not required? What do you think his answer is? See, there are two ways of looking at it. I mean, I don't know whether the initial management was given or not. Initial. If initial management is there in the question, then answer could be echo. If initial management is not there, then the answer could be option D. I tell you why. In the initial management, probably you may not require an echo unless you feel the chances of getting into the heart. Symptoms are there. I'll read through the explanation as given in the book. But once a pulmonary embolism is set in, as a typical case of pulmonary embolism, in that situation, you have to definitely do an echo. You need not do a lower limb Doppler. Let us go through the explanation and come back here. On postoperative day 3 of APR, a patient presenting with tachypnea, chest pain, raises a concern of pulmonary embolism. Diagnostic workup, D-dimer assay, measures the fibrin degradation products and elevated levels may indicate a thrombotic activity but not specific. CT, imaging modality of choice to visualize pulmonary vasculature and direct emboli. Echocardiography to assess the right ventricular function and can detect the signs of right heart strain secondary to PE. Lower extremity evaluates the deep venous thrombosis in the lower extremity, which can be the source of emboli. In this clinical scenario, when all this investigation can provide valuable information, echocardiography is not routinely required in the initial evaluation of suspected pulmonary embolism unless a hemodynamic instability and concerns of right ventricular dysfunction is there. Okay. So again, it depends. In established case of pulmonary embolism, yes, in a final workup, all these investigations are a must. I mean, you cannot rule out, all these are important. The least important in initial investigation could be echo, but in a final investigation, echo is a must. In a final assessment, probably this may not be that important because already pulmonary embolism is there, but one important point you need to understand. Will there be a further source of emboli that could occur from the lower limb aspect has to be ruled out. In case that is there, then you need to put a filter in IVC. So, it's a tricky question. How we take it is important. It's a tricky. I don't know what question was asked. The diagnosis of pulmonary embolism was a question, or initial assessment or initial management is a question. Depending on that, you will answer it accordingly. Do you understand what I say? Initial assessment, lower limb Doppler is important because we should prevent a further course of emboli. For that, we should rule out any lower limb emboli is there. Lower limb DVT is there. But for an established case of a management of pulmonary embolism, lower limb Doppler may not be required because we are going to treat the pulmonary embolism and its presentation. So, you need to titrate what was the question asked, based on that you answer. Okay, which is the least? You can't say all cannot, one is not at all needed, but which is least commonly used? Probably that way they can ask you. But this question is little tricky only. POD 8 MRM, 2 into 3 centimeters seroma, what is the management? See, when you do a modified radical mastectomy and patties, when you remove up to level 3 lymph nodes, and the chances of lymphedema is more, and if suppose there is a postoperative radiotherapy is also added, then definitely the chance of lymphedema is very high. The treatment should be aspiration. So, most appropriate management of 2 to 3 centimeters seroma following a modified radical mastectomy, especially POD 8, is typically aspiration if the seroma is symptomatic and increasing in size. So, aspiration of seroma that are symptomatic, enlarging and retention should be aspirated under aseptic precautions to avoid complications such as infection or delayed healing. Repeat aspiration may be required if seroma reaccumulates. Observation: small asymptomatic seromas can be observed. Antibiotics is not routinely indicated unless the signs of infection, erythema, warmth and fever and purulent discharge is there. Prophylactic antibiotics are unnecessary for sterile seromas. Trauma with splenic laceration 6 cm on CECT with hypotension on presentation responded to fluid resuscitation. What is the management? So, they are responding to fluid resuscitation. That means he is holding. Those 6 cm laceration is there. What is your opinion? So, we have known for all those hemodynamically stable and responding resuscitation, you can manage conservatively, non-operative treatment. Okay. So, grade 3 severe, the category includes such as 6 cm laceration, management guidelines, hemodynamically stable patient, non-operative management, NOM preferred. Hemodynamically unstable patient, immediate surgical intervention is indicated. The patient does not respond to resuscitation. For patients with 6 cm splenic laceration, who is hemodynamically stable after initial resuscitation, non-operative management is appropriate with a vigilant monitoring and readiness to intervene surgically if the patient condition worsens. Thyroid nodule 9 mm, thyroids 2 cm, what is the management? Answer is observation. 9 mm thyroid nodule, thyroids 2 classification is considered low risk for malignancy. Thyroid imaging, reporting and data system is a system used to assess the risk of malignancy in thyroid nodules based on ultrasound characteristics. Thyroids 2 indicates the nodule is benign and has low risk of malignancy. It typically includes nodules that are solid, hyperechoic and have smooth borders. Observation is recommended for the management for thyroid 2 nodules, particularly those are under 1 centimeter in size. Very important question. And the risk of malignancy extremely low. This nodule should be followed periodic ultrasound and monitor if any changes in size and characteristic typically after 12 to 24 months. Okay, so thereby we come to an end of our discussion. I gathered 17 questions of the recall, and then I have made a sincere attempt and efforts to get those references with answers and explanations for your future reference. So that your next exam upcoming of April NESS, and I have put on recall in a general surgical folder. I'll put this in the recall with the other previous year questions. So what I request to you is, you before the exams, suppose a day before the exam, what I will recommend to you is the high yield expected questions which I have done. Along with this recall, kindly just go through once. It may not take more than say 10 to 15 minutes at the max. Yes, if repeats are there and with solid reference you have the answers. Authentic, I'll tell you, authentic. No confusion. Yes, with the clarity we have discussed. So give answers. So that will boost your rank like anything. So we have done new learning from line to line, page to page in all these 3 books. And in detail of repeat, I have not even left any of the recalls for past 5-6 years. I mean, to what my conscious knowledge says, we have almost done all recalls so that you are not missing out on old questions. And we know, so these are the areas, clean contaminated wound, cautery, TPN. So these are areas, na? Yes, typically asked. Yes, MRM, seroma. Repeatedly, these questions are coming from the areas. Pancreas, definite question. Yes. So, like this, you have an idea. Then typically, it will boost our preparation and rank. So, let us have some change in modulations of classes so that the class goes interesting and you learn something new on daily basis. Okay. So, I will see you with bladder 2 and then followed by kidney and ureter. I finished bladder, and then and prostate. I think prostate also is over. Question discussion. Then only testis and penis and urethra. Once done, urology is over. So I have done complete theory of gastro, everything almost I finished in theory. And test and discussion in detail we have finished for gastro, and uro is over. Then followed by that, rest of endocrine, vascular, neuro, all that we will do question and answer discussion. Typically from line to line, page to page, from all the 3 standard textbooks. So, and as my responsibility, from my end, what all I can contribute to you, to the best of the efforts that could help you to exam, definitely will do it. And in with the team of the rest of all the other faculties from their respective specialty, from their perspective of general surgery also they're doing. With 20 to 30% of super specialty standard infused into that, so that anything little more than general surgery is also, they will be able to cover it. Okay. So with that, I sign off from this week from a class for all of you, and keep going, keep enjoying, and keep doing surgeries. And surgery is the best way of relaxation for a surgeon. Okay. Thank you very much. Bye-bye.